Hi everyone, welcome to today's webinar with Mingle Health. I'm Charles Howes, your host, and my colleague Roxanne is joining us. I'll introduce her in a moment here. Our topic today is preparing for primary care first in 2022. So hopefully you all are familiar with this really exciting program. Some of you may have already been starting in the first cohort or are ready to go ahead and dive into the first performance year as the second cohort members. Just by way of introduction, for those of you who may not be super familiar with Mingle Health, if you can go to the next slide, please, Roxanne. Here at Mingle Health, we seek to be your trusted partner in the transition to value-based care. We help you improve quality scores, save time, focus on improving outcomes, and ultimately increase earnings to your practice so that you can reinvest that in better care for your patients. We'd like to also go ahead and take a moment to recognize our clients, our partners, and the frontline healthcare workers who are doing all they can to respond to the continued pandemic. You all likely have felt the brunt of it given your roles in primary care, and we thank you for all your service. Some housekeeping items before we get started. This session is being recorded. We'll send out the slides and recording later this week by email. We also like to make this as interactive as possible, so we encourage you to ask questions in the question box throughout the session. We'll pause throughout as well for some polls so that we can sort of get a quick pulse on where all of you are coming from in your organizations and how you're feeling about the program. With that, let's go ahead and get ready to dive in. I'd like to introduce you to my colleague, Roxanne Thacker. She's the Vice President of Managed Clinical Services here at Mingle Health. She's also a clinical pharmacist who's board certified in ambulatory care in 2013 and has spent, I'm going to say decades, Roxanne, sorry, supporting primary care organizations with care management, patient engagement, and really navigating the ins and outs of these different programs. So thrilled to hear from her today, and hopefully many of you have gotten to know her who have worked with us in the Primary Care First program. So with that, we'll do a quick poll after Roxanne jumps into the agenda.
Fantastic. Thank you so much, Charles, and I'm excited to be here with you today to talk about some of the upcoming changes for 2022 and what to expect. First, I wanted to spend some time on, like I said, just a quick overview, some of the things coming up, some of the changes to attribution and remote care, then really look carefully at the quality measures and what are the 2021 reporting challenges, what are the challenges going into 2022, and certainly any changes. I also then want to just touch on the acute hospitalization, hospital utilization measure and total per capita cost, figuring out, do you know where to find that performance at this point? And then taking a look at leakage and send you back into your regular lives for that. To kick it off though, we have a poll just so that I understand who I'm speaking to. So Charles, can you cue that up for me?
All right. We'd like to understand just who's joined us today, how your organization's participating in the program, or if you're, there's many supporting organizations and people as well. So feel free to just put NA if you're not directly participating, that's fine too. We'll give it about 10 more seconds. Thank you all for voting. So it looks like, Roxanne, we've got a bunch of cohort 2 folks joining us, but also a bunch participating in both cohorts. So folks who have gotten some experience already with the program, but then need to look at what's coming. So just to share that back to you all, we've got 38% in both cohorts, followed by 19% in cohort 2. And then 13% in cohort 1.
Awesome.
All right.
Okay. Well, thanks all. So the most important part of my agenda is your questions. So as you have questions, throw them into the chat. I will try to make sure that we have plenty of time at the end to answer your questions, as those are the most important ones anyway. So As an introduction for first, remember CMS has some fundamental goals that are driving primary care first. First is to create a simple payment model. There are certainly challenges saying it's a simple payment model. Nothing's quite as simple as we wish it was. Next, CMS wanted to provide prospective money, money that you have in advance to foster and to develop new care strategies or to do things that might be out of the norm for practices. Next, they want to set goals that are important to both patients and providers. That's where those quality measures come in. There also should be financial rewards for higher performers, right? When we were in school, we got grades, and maybe our parents gave us some money for better grades. So, and quite frankly, money motivates. So I'm not immune from that also. Documentation burden has also been recognized as a major challenge by CMS, and they're getting the money to pay for those financial rewards from reducing hospitalizations and ER use. So that's a really important fundamental aspect of the program that they're really trying to drive. Patient access and engagement has become a bigger and bigger issue over the last 18 months, particularly with the pandemic. And CMS is allowing for some additional flexibility because of that. And I think that will really help practices if they're implementing it well. CMS is also looking for best practices. How can they roll this out to other places, or what are really the best methods to make sure that patients are doing well and that providers are having good success? And last of all, they really want to give you access to data and analytics that are helpful because the data and analytics are critical for you to know where you're going, where you've been, and how your quality improvement goals are working out. So year one, whether you're in cohort 1 or cohort 2, year 1 is going to be 21, obviously, for cohort 1, and 22 for cohort 2. So in quarter 1, we have the program kickoff. You should be reviewing your attributed patients, pardon me, reviewing an attribution plan, figuring out who isn't attributed, what are you going to do about that, why might they not be attributed. Going into quarter 2, you probably need to start looking at your quality measures. And we'll talk more about this momentarily, so no worries here. The registry versus claim measures and ECQMs, depending on your group assignment again. 1 and 2 have 3 ECQMs in addition to the PEC survey and advanced care planning, while group 3 and 4 for this year have just the advanced care planning and PEC survey. Next year, they will have days at home, and we'll talk briefly about that as well. In quarter 3, you want to be looking at your attribution efforts that were happening in quarter 1, because remember, it takes that 90 days to get that measured and patients to get onto your attribution roles. So did your plan and your activities in quarter 1 really impact your quarter 3 attribution? You're going to need to start reviewing your total per capita cost, acute hospital use, identifying high risk, high cost patients. And at some point, typically in that quarter, you'll be providing a patient list to CMS for the patient experience of care survey. In quarter 4, sorry, I had a typo there. The survey, the PEC survey, will be administered to patients. Again, reviewing attribution was what happened in quarter 2, reflected in quarter 4, and then you should be making sure you're ready for your quality submission that would technically happen in quarter 5. All right. Now for year 2, again, if you are a cohort 1, this is what you're going into. So 16 days, you'll be in year 2. During that first quarter, you're going to do your quality submission for the quality gateway, review your attributed patients, and review acute hospital use and total per capita cost. Some of that information is in the data feedback tool. I'll show you where that is coming up. Quarter 2, again, reviewing your measures, benchmarks for year 2, evaluating where you need to go for the next year. And there are some pretty significant increases in performance that will be required in year 2. You're going to be preparing for your leakage assessment, and performance bonus monies are going to be paid in Q2 based on 2021 performance for cohort 1. Cohort 2, obviously, it would be for 2022. Quarter 3, really starting to dig into HCC and RAF scores. Certainly, if your practice is ahead of the game, you can start that much earlier. However, it might be really difficult to see where you're at depending on what tools you're using. Look at your leakage. You'll be evaluating the financial implications of that, and again, doing that patient list for the patient experience of care survey. And then, of course, Q4 looks much the same in year 1 as it does in year 2. So when I say reviewing your patients, figuring out who they are, there are a few changes coming in 2022. The first one, and the first way that patients can get attributed, is through mymedicare.gov. It can be a little clunky to get through the system. Certainly we have some tools, some forms and things that can guide patients through that. Chronic care management is no longer going to be a attribution methodology on its own. Each independent billing will count as a touch point, certainly, and will count as part of plurality, but it will not be its own attribution methodology. So if you've been really leaning on that as a method to get patients attributed, this is going to be a big change for your organization. AWVs will continue to be an attribution plan, and then plurality of care. My one caution with that is that if you are a practice where you have a fair number of new patients coming in, plurality is going to take a full 24 months for you to get plurality of care. That's going to be a big challenge. At a minimum, you're looking at probably a year unless there's a significant change in this patient's health and the number of visits that they're getting. HCC scores and diagnosis codes, super important from the very beginning. Your group assignment is based on the patients that are attributed to your practice. Let me say that again. The only HCC scores that are used to calculate your group assignment are the patients attributed to your practice. So if you're only being attributed with some of the most healthy patients because others are seeing other providers and all over the place, then your group assignment might be less than you would expect. So that's something to really think through, making sure you have the right patients attributed. Last of all, patients get attributed with that 1 quarter lag. So any services that are happening in Q4 of 21 won't be reflected until Q2 of 22. So when you're looking at your attribution plans, remember you have that 90 days of measurement time or downtime that CMS is using so that they can get the right attribution information out. This is a case study for a client that we've been working with for some time, and we started working with them prior to the program kickoff for cohort 1. Their initial attribution was 378, you can see on that top line. They were really concerned. Their average patient panel across all of their providers is somewhere between 12 and 1350 patients. And so they were really concerned that they were missing a big chunk of their patients. So they started working on annual wellness visits, getting them completed, finding the patients who needed that service. When program kicked off in 21, their active attribution had increased by 150 patients, which resulted in a $70,000 increase over what they were projected prior to the program initiation. Q2 and 3, we continued to work on that AWV promotion, finding patients that are attributed, making sure that the right patients were getting attributed. So that number has continued to grow quarter over quarter. Please note the difference between active attribution and cumulative attribution. Active attribution is patients who are alive and still active in the practice, where cumulative attribution would also include patients who may have passed away, are in hospice, or have left the practice. So quarter over quarter, they're seeing significant gains despite the fact that they have patients who are also exiting the practice for a host of reasons. Last note on this one, because of their focus on annual wellness visits, they've also captured fee-for-service revenue associated with their annual wellness visits. $150,000 is nothing to sneeze at, and certainly if you want to send that money to my bank account, you just let me know. I will get that taken care of. So let's talk about real world. Let's do a quick poll, Charles, if we could, about site attribution, how they're experiencing that.
Absolutely. So yes, if folks could just give us some insight into the reports that you've received for your attribution, how has that been as compared to your expectations? Give it about 10 more seconds here. And if you haven't quite seen the report yet, feel free to put, give it a guess or your instinct. All right, just a few more seconds here. All right, and it looks like we have quite a mix. Several folks indicated that it was right about what they expected, but then we have a full spread across the spectrum of it being higher or a lot less.
Okay.
So thank you all for sharing that. So we had about 58% say about what I expected, 50% each for a bit less and a lot less than expected. And then some folks higher than expected. So thank you all.
Thank you. That's helpful to know. we also have another question. If your attribution was less than expected, have you planned or implemented an attribution plan or a remediation kind of action set? So that poll will be up momentarily.
Let's go, it's launched. Give it a little moment here. Yeah, and you can answer this too, even if it wasn't less than expected per se, since so many did say it was right about as expected. We'd love to hear too is, have you implemented a specific plan focused on attribution? So you can answer it that way as well.
That'd be great.
Seconds. All right. Well, we are still early in the program, so not necessarily surprising. A lot of folks here said that they're still in the planning phase.
Okay.
79%, and then 16% have started implementing a program.
Fantastic. The attribution plan certainly can be a lift, and one of the biggest challenges I've seen across most of our clients is that they don't have the right tools for that. And it's also not payer agnostic, right? We're having to focus on those CMS patients to get the right ones locked into the practice. It's not surprising that that has been a challenge. Most EHRs are not going to show you attributed versus not attributed. You're going to have other tools to show you that information. And here at Mingle, we've definitely worked really hard to get you the tools so that you can see that information, and also at the same time, see who due for that AWV. That will allow you to either focus on them to get their voluntary attribution done, or continue to work on your wellness visit program and focus on those patients that are not attributed while still supporting the patients that are attributed. Remember, the sooner you make changes in that, the sooner you will see effect. I wanted to talk just a minute about maximizing patient engagement. And this goes back to some of the changes associated with the pandemic and telehealth. So often, as I've spoken with different clients, they've said, well, we've gone back to seeing all of our patients in the clinic. Okay, that's great, but are you offering telehealth as a viable option? Is it something that you're utilizing for patient follow-up? Is it something that your nursing staff or your support staff are using to engage with patients in their homes, where they're living day to day? Are you needing to see patients physically face to face every single month, or are there better ways to engage with them? Are there, would a phone call work for some of the follow-up that you're needing to do? This also lends itself to the set of questions about, do you have the right number of care coordinators for your patient population? Are you encouraging a balance of office visits versus remote support? I will freely admit, telehealth has absolutely been wonderful for me and my family and my aging parent, because I'm not having to take off as much time to go and sit in a doctor's office. I can, send him to have labs done and then follow up with the doctor. And even if my dad, for instance, wants to go see the doctor in person, I'm still able to engage and participate in his care. As you're working on those things, are you impaneling your patients, not just to providers, but also to care coordinators? Are they the right people? Are they the right fit? So often we forget that not everybody is good at taking care of everybody. And I've been in care management, like Charles mentioned, for a couple of decades. And every location I've been in, there have been a handful or two handfuls of patients that I just didn't connect with, that I really needed someone else to help support because their challenges or their communication or their personality just didn't really jive with mine. And I wish that I could say I was perfect. However, recognizing that there may be other people who can reach those patients in a different way can be really important to their care journey. As a news note, the COVID telehealth waiver that was first implemented about a year ago has now been extended for the entirety of the Primary Care First program. So think about using this for your frequent hospital users, your ED users. You may not need them to come into clinic for follow-up, but they also need that outreach. They need that support. Are there multiple chronic disease patients that you should be following up with in a different kind of way? Are they getting their medications? Does it make sense that, instead of bringing them into the office, if you are dealing with a medication issue, that is a different kind of visit? Social determinants of health, I think all of us have been impacted and understand the consequences of that. And then recognizing that the providers and the staff really have a great pulse on which patients are headed on the slide down, which patients are at the bottom, what do we need to do next? So that is going to be most predictive across all of your patients. So again, let's throw a poll up on your screen. And EHRs do not typically have the best care management tools. I know, because I did this for a long time. So let's find out if you have the right tools.
All right, we've got our poll live here. Give it a few more, about 10 more seconds here. So far in the lead is it seems like many groups have some tools and are mostly able to track care. So it's working, but it's not necessarily, all the tools they need. Next up is we do have a set of people who are saying care management is a challenge and they're still looking for tools to make that more streamlined. And about 15% have shared they have all the tools they need and are fully engaged. So great to
Outstanding.
hear.
That's wonderful if you have all the tools you need. Here at Mingle, again, we have some additional tools for care management. So if you're looking for tools, we'd be happy to talk to you, share what our tools look like, and see if they would be a fit for you. And absolutely, they may not be a fit for everybody, but we want to make sure that you have access to what you need.
Roxanne also points out as what we really enjoyed is a few weeks ago as we shared lessons learned among the practices and organizations that we're supporting in the program. What tools are working for them is a conversation we like to have with our customers and help share that among the other organizations that we partner with.
Absolutely. So if you are, one of the practices who has all of your tools figured out, put a message in and we'll take a look and share that with everybody. Healthcare is definitely a learning process. So we're happy to share that information across the board. Quality is the next point that I really want to focus on. Remember, the quality gateway is a pass-fail. It's not like MIPS, where the better you do, the higher your score. Quality gateway is just you get through or you don't. In 2021, you're going to have ECQMs if you're a group 1 or 2, in addition to the advanced care planning and PEC survey. But for groups 3 and 4, you're going to be doing just the advanced care plan and PECs. In 2022, there's a major change coming for advanced care planning. I'm going to talk about it more in depth coming up, but you have to submit CPT-1 or CPT-2 codes. Those are also called quality data codes. You may have heard them called QCDs. So those are some things that we're going to talk about specifically. In your cost measures, what your PBA is based on, your acute hospital use, total per capita cost. Do you know where you are? Have you used the tool? Have you used the data feedback tool? Do you have any guesses on where you're at in leakage? Any idea if a specialist is billing with PCP codes or, they're identified as a PCP? And then certainly the PBA goes back to those cost measures. Did you do enough to get a bonus? Are you through the gateway? Now you're into, those cost measures and certainly improvement in your practice. Those are really important things and things that you shouldn't wait till the last minute. Don't be surprised. Take a look at the data that you have access to and certainly the data that we have some access to as well. This is a review of the quality gateway points. The PBA-based measure is listed there at the top. In 2022, for groups 3 and 4, they are adding a days at home measure. This is a brand new measure. It will be claims-based. I'm going to talk more about that in just a moment. This is a review of the measures for the gateway for 21 and then 22. As a note, please remember that the diabetes measure is an inverse measure. So the lower the number, the better the performance. In 21, your performance could basically be abysmal. Let's be honest, it's abysmal. In 22, that measure, that standard is really moving quite a bit. That's a 30% increase in where you need to be as far as your diabetes population. Blood pressure has a pretty significant increase as well. So you're going to have to really focus, figure out where you are right now. What are you going to do to see improvement? The colorectal cancer screen has the biggest change. It is a factor of 10 change. One of the biggest challenges across ECQMs is that it has to be documented in the place that the EHR is looking for it. If it is not documented in the place that the EHR is looking for it, it doesn't matter if it happened or not. The system doesn't see it. So make sure that you have a good understanding of what your performance is and make sure that all of the providers are documenting the same way. That's almost like herding cats. Yes, I am totally aware of that. The advanced care plan measure isn't moving a whole lot. The challenge that we're seeing across our clients, and certainly with our history in MIPS and other quality programs is it's not getting to the actual benchmark, it's getting to the data completeness requirement. 70% of your patients have to have a QDC code related to advanced care planning. It's really easy for us to code for something that did happen. We asked them about advanced care planning, or we reviewed their advanced care plan, or made sure that that was still current. However, for patients that we didn't ask that, you have to send out the QDC code that says they're not met. That is where we're finding the biggest challenge across our patient population and across all of our clients' patients. This is a challenge. Nobody has used claims. CMS has been driving away from claims, and now we're going back to it. So no, you don't need a qualified registry. However, you do need a way to track that. The other thing to recognize is that the QDC codes may go out on your claims. However, many of the processors scrub out the $0 claims. So the QDC codes may never get to CMS. How are you monitoring that? Do you know what to expect? Do you know who to talk to? All of those are critically important. The PEC survey standard isn't changing, and the days at home, we don't have a benchmark yet that has been released by CMS because it is a brand new measure. It will be interesting to watch how that is going to develop. The advanced care plan reporting changes, again, I've kind of already addressed this, but let's just pretend your billing system isn't ready to do accurate CPT2 codes until, say, July 1st, right? Not unusual to have a 6-month implementation time. So think through how many patients were seen in the first 6 months of the year that you may not see again, okay? If that number of patients is 30% or higher of the total number of patients you'll see in the year, you won't pass the gateway. You will fail getting through the quality gateway. That means an automatic 10% penalty. That's a lot of money, and that is going to have a significant impact on your organization. If, however, that number is close to 30%, that means you're going to have to be 100% accurate with all of the patients remaining through the year. If your organization is 100% perfect at anything, please let me know because I'm going to move there. Nobody is 100%. I wish we could say that we were. You've also got to plan for some ramp time. So getting on that, starting to work through those challenges immediately is going to be critical. If you don't have a plan for monitoring, we have the tools necessary to do that. We can also look at your 837s or your billing files and scrub them against the CCLFs, your claims line feeds that are coming back from CMS, and really make sure that what you think you're sending is what is actually going to CMS. Those are some things to think through as you get into 2022. How is that going to work for you? We don't know at this point if CMS is going to share your performance on that measure before the end of the year. Again, remember there's that 70% data completeness. I'm not worried about anybody performing at less than 4%. I am incredibly concerned about that data completeness piece. And always CMS has the right to do audits. Are you reporting accurately, not just reporting? ECQMs can be a challenge because that data has to come straight out of the EMR. You can't manipulate, you can't add clarification. That has to come directly from the EHR and however it is pulling that data. Documentation has to be where the report within the EHR is going to find it, meaning all providers have to be documenting it in the same way and in the same place. Again, I recognize that thinking through that is like herding cats. I have never met 3 providers who document all the same way. None of them do. Some of them are similar, but it will be a challenge if you have multiple providers in an organization. For the ECQMs, you're getting a reporting rate for 100% of your patients. all patients, all payers. Something to kind of think through. It is payer agnostic, so you're going to be seeing all of your performance across all of your patients. The days at home measure a risk-adjusted claims-based measure. So risk adjustment means that they're going to look at patients who have a similar HCC score and then risk adjust that, to my understanding. It's going to measure the number of days a beneficiary is remaining outside of an institutional setting, like a hospital, a skilled nursing facility, a rehab facility, and the standardized time period will likely be the entirety of the year. However, as we're looking at attributed beneficiaries, we're only going to be looking at that days at home measure for the time that they're attributed to your practice. So if you have a patient who's only attributed to your practice for the last 90 days of the year, it's not going to count against you that they were in a rehab facility before in your practice. Hopefully that helps clarify a little bit. We don't have final measure specifications, so there is still a lot of a question out there. The benchmark will be evaluated from a benchmark population. They're going to be looking at other practices, other patients across the country and through your peer region areas. Another change coming in 2022 is that concurrent benchmarking will be used in 22 going forward. CMS and all of us have recognized that looking back 2 years, particularly in an era of pandemic, doesn't necessarily reflect what is happening with our current patients. As a result, concurrent benchmarking will now be implemented instead of the retrospective benchmarking that has been used previously. For 2021, the acute hospital use benchmark is 1.16, and the total per capita cost benchmark will be determined by deciles. It's divided into quarters, bottom 25%, bottom 50%, top 25, and middle 25. So it moves by 25 percentages. Now let's talk about the real world. What's going on in your experience? What's going on in your practice? There is another poll we have for you, I think.
Yes, launching that now. So this one will let you pick multiple answers. So we'd encourage you to let us know, have you reviewed your quality measures first? And then how are you feeling about what you're seeing with your performance on those measures? So if you could pick one from each of those sections, that would be helpful. All right, it looks like most attendees have looked at some of their performance.
Great.
There's some who have looked at only some of it, or are planning to look at soon. And then about 32% right now feel like they're performing well. 20% wish some of their performance was higher.
Okay.
So we'll give it a few more seconds here. Thank you all. And just to share that back, so it looks like a mix. There's some opportunities for improvement, and there's some bright spots.
That's great to hear. Quality performance is a challenge and is a focus in value-based care. We have to basically prove that what we're doing is making a difference. That can be an exceptional challenge across challenging patients and across patients who may not be as challenging. When you're planning quality improvement work, remember it's important to start at, laser focused. Being able to track how those actions are impacting your outcomes can be critical to drive change. If you can't measure it, you can't change it. Make sure that as you are implementing quality improvement changes, you're able to measure it and you're sharing that data back with those who are performing. The providers, the staff. Healthcare has fostered this competitive nature in all of us, whether we like to admit it or not. Knowing that I'm not in the top 25% can be highly motivating. Maybe it's not motivating to some of the providers, so you have to come up with different motivational tools. Even some of your staff members are motivated by knowing where they fall. Coming up with fun ways to track and to share that information can really foster team spirit in your practices. So think through those things. Certainly engage with your providers at the practices. Come up with ways to really drive that change as you need to. Leakage information. I'm sure everybody has kind of started thinking about it, maybe. Leakage information is available on the Primary Care First data feedback tool. The information right now that is available through Q2 of 21. So that means you can see data up through June of 21. The attribution reports have some of the same data, but this is much more visual, certainly. If you don't have access to the dashboard, you do request access to the data feedback tool on the portal where you get your attribution lists. Please note, one of the biggest challenges for CMS is getting data to practices in a timely fashion. That's not a new thing, but use the data that you have, recognize where you are, really look at the expenditures. Who are the beneficiaries that are driving your expenses? Is there a particular practice that your beneficiaries are going to that they're being billed as if they were primary care? Great example, one of the practices we were working with had and still has, to my knowledge, a cardiology clinic down the hallway, essentially. When they started looking at the leakage and the expenditure breakdown, they discovered that one of the cardiologists had a primary care designation and was billing primary care codes. As a result, they needed to have a conversation with the cardiology office, figure out what they could do to make sure that patients didn't get pulled or it didn't end up as leakage because the patient really needed to see cardiology. It was a matter of recognizing what was happening, intervening, making an attempt to navigate through that process with a provider who was providing care for these patients. The cardiologist didn't want them attributed to her. She really wanted them attributed to primary care. So figuring out what they needed to do was really important in that process. Your leakage calculation will be applied to payments in Q3 of 2022 for cohort 1, and then Q3 of 23 for cohort 2. A couple of exclusions. The leakage has changed just a little bit for 22. It's going to exclude all services furnished by PAs because there's not a way to designate whether a physician assistant is a primary care or a specialty taxonomy. Leakage is also going to exclude nurse practitioner services that are associated with acute care and women's health. Most internal med providers don't want to be doing women's health specific stuff. It also narrowed the definition of primary care practitioner and added a place of service restriction. If you need more details about that, certainly look at the payment methodology that was released for 2022. And if you have more questions, put them into the chat. We can definitely talk more about it if that's a big question. Many of our healthcare provider shortage areas were missing out on the bonuses that were paid to fee for service. As a result, CMS adapted and will add the shortage area bonus payments back to those difficult areas to get healthcare provider coverage. In a perfect world, leakage wouldn't be a concern, but it's not a perfect world. Think about, are you concerned about your leakage calculation? Do you even know where you are? Have you looked at any of the CCLFs or the claims feeds for your attributed patients? Do you have access to the data feedback tool? If the answers to those are somewhat mixed, you have an opportunity to really engage more deeply with the data and the analytics to see what's going on in the practice. As always, there are challenges succeeding in primary care first. I will be the first one to say there are a lot of moving parts, and it is a challenge. It's a challenge to track, it's a challenge to know where to go, it's a challenge to have the right tools. Here at Mingle, we've been dealing with data for, since 2012, so nearly a decade. We understand where the data is coming from. We understand that there's a lot of places it can be coming from, and we're able to really mash that data into a place where you can analyze it, you can see your quality scores, you can see what's changing. And we have an amazing team of people who can help you to navigate through finding answers and establishing quality improvement plans, and then really seeing if those plans are working. It's critical in this process to optimize your staff. Make sure and think through, are they all delivering at the highest level of their license? Providers don't have time to do everything. I absolutely understand that perfectly. Providers do not have time to do everything. So who in the organization, who in the practice can do a host of different services to support these patients in these programs and to really drive your participation in value-based care? As always, Mingle is here to be your partner in value-based care, and I look forward to hearing from you and seeing some of your questions.
Thank you so much, Roxanne, for sharing that walk through the two performance years, early performance years for PCF and looking at 2022. We did get a few questions in advance, so we'll head to those shortly here. If folks can go ahead and put your questions in, please. We have our first question here from Cherise.
Okay.
So if we have a nurse practitioner that does family medicine and does women's health, do those patients need to see an MD or a DO at some point in the year to be counted?
If they are doing women's health, it is my understanding, yes, to have them attributed, you would want to have, but at the same time, if they are on your provider list for primary care, then you should see patients that are attributed to that NP. They would not need to see the MD or DO. However, the services that that nurse practitioner is providing, they're all going to fall into your same primary care, but you won't see the visits for women's health being counted as part of your total primary care services. So as you're looking at leakage, that's not going to impact your practice as leakage. Great question.
Yeah, thank you for that question, Cherise. If you have a follow-up, feel free to put it in. All right, so this is the time for questions. So please go ahead and pop them into the chat and we'll take as many as we can. Let's go ahead and on to our pre-submitted questions.
Fantastic. Pat asks, when and where can we get a list of attribution? I'm assuming what you're looking for is a list of your attributed patients. For cohort 2 practices, pardon me, that information will be released in January when you get your first prospective payment. That information will be housed and is housed on the PCF portal. That's that portal.cms.gov. Make sure that you have access to that so that you can see all of your patients, download a list, and start to navigate through that list. That's a great question. There are 5 different websites that you need to be able to navigate in PCF, and that certainly can be a big lift.
Great question. We have another one from the live audience here from Nina. Are the practice groups the same as the ones in CPC Plus? So when looking at the data feedback tool, My Regions, averages are listed. Is that the same thing?
It will be close. It will be close. I have not taken a look at that to know if they're exactly the same, but I would guesstimate that they will be very close. That's a great question. Given that CPC Plus practices are coming straight across into PCF, then it would make sense to me that they would be the same. I will definitely check that though and make sure that I have a better answer, or can definitely reach out to you directly. Thank you so much for the question and identifying an area that I need to learn a little bit more about.
Getting access to what CMS is providing is definitely a challenge for many, as well as, you know, when to look and, you know, how to use it to guide their decision making and their implementation. So it's something that we're constantly working and helping folks discover.
Right.
We've got a question here from Ruby. Where is the PCF data feedback tool?
Sure. So it is also on the PCF portal, but you have to request access. When you log in to where you would go to get your attribution list, then there's a box that says innovation. Then you click into the little line that's below that. And when you get to that screen, then it says PCF/SIP. At the top, there's a button that says request access, and you request access to the electronic data feedback tool from there. There are some documents that CMS has provided through the PCF first edition. And if you would like me to send you the link to that again, I would be more than happy to do that. Thanks so much, Ruby, for asking, and certainly I will reach out to you directly as well.
Wonderful. All right, let's head back to our pre-submitted questions here.
Fantastic. Sarah asks, what services will Mingle offer for PCF participants? We have a pretty broad array, actually, of services, depending on what it is that you need. Everything from monitoring your quality so that you can see, are you performing well on your claims measures? Are those CPT2 codes and CPT1 codes getting to CMS, or are they being scrubbed out? What does that look like? We can also support monitoring your ECQMs. We'd get a file uploaded onto our dashboard and you can see that. You can see whether you're passing or failing. We have practice coaches who will engage with you to support you through questions and help you to find a experience of care survey vendor. We have attribution tools and care management tools, depending on what your practice needs. We can meet a host of different challenges that your practice is facing right now. We don't have providers that can come to your practice, but I have some amazing staff who can support your efforts and your work and the efforts and work of your amazing teams. That's a fantastic question.
All right, I think there might be a few more that got pre-submitted. Fingers crossed. But but before we dive into the answer, I'll just do a last call for questions from the audience, just so we are mindful of your time. All right, back to you, Roxanne.
Fantastic. So Summer is asking about the acute hospital use performance bonus for 2021. Will it be paid out in Q3, Q4? It is my understanding, based on what is in the payment documentation for 21 and for 22, your first payment will land in Q2 of 22. And it's going to be retrospectively looking at 21. I think I have that slide. Here we go. You can see participation in 21. In that purple is your performance period. There's the measurement quarter in 22, also making sure you got through the quality gateway, and then the payment of that performance bonus in Q2 of 22. and then it proceeds from there. It's that rolling 12-month period. So it's looking back. If you're wondering where I got this figure, this picture, it's actually from the 2022 payment methodologies document. CMS sent links out to that, I believe, in the Primary Care First edition and the PCF First edition document, and you can also access it through the CMMI portal, which is kind of like Facebook, that you're able to interact with other participants. It is in the resources section.
Yeah,
And
great question. This visual helps with the dynamics of the timing.
yes, absolutely. So keep going. We have a couple of minutes left. If there are more questions or you still are feeling unsure about something, I'm happy to go back to a slide and speak more to it if that would be helpful.
Yeah, wonderful. We've got 3 more minutes, so feel free to give us our last question, anyone who's still with us. I'll take a moment just to say thank you all for joining us today. It's been a pleasure to work with the organizations we are already supporting in Primary Care First and learning from their practices, what's working, where their challenges are, and how everyone's taking advantage of this exciting program, hopefully to streamline and simplify the delivery of advanced primary care, which all of you are experts in, and always sharing new ways to provide care. And Roxanne, thank you so much for sharing your knowledge as well.
Absolutely. I so appreciate all of the practices that are working with us, who have shared information with me and continue to teach me so much about value-based care and what they're doing in their practices to really move us all forward. Thank you again so much for participating. I just really appreciate all the great work that you're doing.
We don't have any final questions, so I think we'll go ahead and end it there. Thank you,
Fantastic.
everyone. We'll send out the slides and the recording later this week, so be on the lookout for that, and we'll pop in as many resources as we can to that message. Have a wonderful rest of your day. Thanks all.